Good afternoon, everybody, and thank you for, I don't think the mic's on. Okay, there we go. Hi, I heard that there was a spicy conversation over the last unconference session about what is a provider. What a better way to introduce the next panel. Joining us today is an expert panel representing pharmacy and pharmacy interoperability needs, so I'd like to turn it over to them. So thank you all.
Pharmacy is already rising to the challenge.
After the pandemic and during the pandemic, we saw what a great role pharmacists can play, not only in doing vaccinations, but also test to treat and other clinical services.
When I was in the ICU way back when, as a fellow, we had our first PharmD that actually came on rounds with us. And it was like an angel descended from heaven. This person who was able to go through all these complex medications and make new prescribing guidelines and understand the drug-drug interactions and how we could better dose to treat people. And I was just amazed because this was all things that I didn't know that the pharmacist brought.
Asthma, COPD, a lot of these care services, pharmacists can actually help with.
We are working federally to allow pharmacists to be providers under Medicare Part B so they can provide services to Medicare Part B beneficiaries. Pharmacy has made quite a bit of progress on interoperability, but there's still a long way to go.
Interoperability means getting the right data to the right care team member at the right time to help patients improve their outcomes.
We're also working very hard to make sure that the care team, as it evolves, have the information that they need at their fingertips to provide the care that they are allowed to provide at the top of their license.
We need unity, but not uniformity. We're not going to have uniformity in healthcare because we're all doing different things, but we can at least be united on a specific goal or a specific endeavor or a specific purpose. And I think that's okay. Let's identify what we can be united on and let the rest be what it is.
Well, good afternoon and welcome back from lunch and the unconference sessions. As your moderator today, I hope that the video here really did some of the heavy lifting in terms of setting the stage for this particular panel discussion. Kind of feel like the teacher who puts on a movie at the end of the day to get out of teaching. But in all seriousness, my name is Meg Murphy, and I am the Pharmacy and Regulatory Affairs Manager at Surescripts. I am a pharmacist, and I co-chair the pharmacy work group that kicked off through the Interoperability Matters program earlier this year. So we have now over 45 different organizations that are participating in the work group and interested in the work group. And so today, for this conversation, we wanted to bring sort of a flavor for the conversation and topics that we're covering in that work group. And I think, as was mentioned, the session before this and talking about, what is a provider, I think as the video demonstrated at Surescripts, we really can see that pharmacists are playing a key role as a provider on care teams. And so really excited to have this panel with me. These gentlemen are all participants and sponsors of the work group. So would love to turn it over to them to introduce themselves And we're going to kick it off with, tell us why is now the right time to prioritize pharmacy interoperability? What's changed that makes this more urgent or more possible than before in your view? And we're going to start with Kevin.
Starting with me.
Yes.
Okay. Well, actually, I have some slides. Can we tee up the slides? So I'm Kevin Nicholson, Vice President for Public Policy, Regulatory, and Legal Affairs at the National Association of Chain Drugstores. And I just wanted to run through some progress that's been made over the years on expanding pharmacist scope of practice. Some of you may not be aware of exactly what pharmacists are allowed to do in the states. Pharmacists have the ability, by virtue of their training and their education and their expertise, to provide services, but there's a question over what actually are they allowed to do in the states. So as you can see on this slide, about 16 states allow pharmacists to initiate, to test, to administer a CLIA waive test, and to initiate treatment for ailments such as flu, strep, COVID-19, and UTIs. Next slide, please. And then here, in about 2/3 of the states, we see that pharmacists are allowed actually to order preventive therapies for such things as PrEP and PEP for HIV prevention, hormonal contraception, tobacco cessation, statins, therapies for uncomplicated minor ailments, and naloxone. So we've made quite a bit of progress in these states, and we're hoping to expand that as well. Next slide, please. Here, this is where pharmacists are allowed to order and administer non-COVID vaccines. Basically, pharmacists are allowed to do this in every state. And the type of authority varies from state to state, whether it's tied to specific vaccines or to CDC and the Advisory Committee on Immunization Practices. And some states some states in white aren't very prescriptive at all on the vaccines that pharmacists are able to provide. Next slide. And I wanted to break out COVID vaccines in particular because there was controversy earlier this year before CDC acted over whether a pharmacist could order and administer a COVID vaccine. And 22 states just this year took immediate action to make sure that a pharmacist could provide a COVID vaccine. So states are recognizing the value of what pharmacists can provide to patients. Next slide. And here, this is sort of a similar slide to what you saw in the introduction. In 22 states, Medicaid covers pharmacist services, and in 16 states, either commercial plans are required or are providing coverage for pharmacist services. Next slide. And then finally, I just wanted to show the progress that we've made just this year. The states that are in color are states where NACDS has worked to pass legislation to expand pharmacist scope of practice. So to answer your question, Meg, this is sort of a long way of saying that pharmacists are being recognized in the states for what they can do for their value, and they need data. We need to be interoperable in order for pharmacists to be to adequately provide the services that they are being allowed to provide.
Awesome. Thanks for kicking us off and helping us set the stage. Jake, I'm going to turn to you next. What, in your view, is kind of making pharmacy interoperability more possible, more urgent?
Perfect. Thanks, Meg, for the question. So my name is Jake Galdo. I am a community pharmacist, so I put pills from the big bottle to the little bottle. I help patients. At the same time, I manage a network of community pharmacies from New York City to Honolulu doing enhanced care services. So they are billing medical providers, not PBM providers, for their services that they do, the things that we're talking about here. And then finally, as Seguridad, we actually produce and implement quality measures to differentiate community pharmacies, because we believe that all pharmacies are not the same. And we actually represent a white label data warehouse for pharmacy interventions in various states like Missouri. So we're doing a lot of crazy, cool things. But why is this so important? Is because I can think of an independent pharmacy in Missouri, and it's a small rural town. They have one street light in that town, so you can now start to imagine it. It is a town that when patients come to the pharmacy, they ride their lawnmower because that is their mode of transportation. The pharmacy has over 800 patients on a care coordination program where the pharmacy touches base with the patients every month to see how they're doing. And in September, we implemented migraine screenings. So for those that don't know about migraine, you can do an ID migraine. It is a validated tool to screen somebody for migraine disorder. It's a whole thing, so migraine disorder. And the pharmacy found a bunch of patients that had never known that they had migraine. They just thought, I have a headache, it's fine. And so all of a sudden, the pharmacy now has the clinical data, it has prescription data, it has a whole heck of a lot of information tied to the care of a patient. And we need to find a way to get that to other people. And so if you're asking why is it so important for interoperability right now, it's because we're doing more than putting pills in a bottle. We are essentially screening and identifying persons with migraine disorder, and we want to connect them to their providers to close that gap and get them appropriate therapy.
Awesome, yeah, just one of the many examples. Ben?
So good afternoon, everybody. I'm Ben Bluml. I'm a pharmacist. I work for the American Pharmacists Association Foundation, celebrating my third decade there, and I serve as our Executive Director and Senior Vice President for Research and Innovation. Over those years, we've implemented dozens of patient-centered, team-based care programs where the pharmacist is well integrated into delivering services, many of which have been outlined on the slides thus far, and what Kevin and Jake have been describing. The important things that I think this audience needs to hear are that pharmacists consistently need information about what's going on with the patient's medications. That's not a surprise. So an accurate med list is at the core of our concern, because when you think about many of these conditions that we've been discussing so far, medications are the primary treatment modality. But they also need access to the patient's progress notes, to lab values, and to other data in the patient's chart if they're going to be a part of that team who helps to make the best therapeutic decisions for optimizing medication use for those patients. So I'll hold it for now and turn it back to Meg.
Great, thank you for those examples. I mean, I think what I'm hearing so far is that pharmacists are providing care, in spaces across the country. And I think Pooja, my co-chair of the pharmacy work group, said it really well on the video that, you need to be able to get the right information to the right care team member at the right time. And so want to talk about, when that does happen. So when the pharmacist, does have that improved data exchange, what's a real world example of how that's improved patient outcomes in the pharmacy? And Jake, I'm going to go to you first.
Thanks, Meg. So, I want to highlight two things before I give my story. And the first is Ben's talking about data coming into the pharmacy, which is just as salient as data that I can collect and push out. So I want us to think about it as it's two ways, right? Because again, the ID migraine, I identified the person with migraine disorders, and I want to share that with others just as much as I need that care note to know, has anybody ever done the ID migraine to them? So when we think about ways that this is working well right now, I call out NCPDP. They have script standards, they have data elements, they have data exchange between electronic prescriptions from a prescriber to me in a community pharmacy. And I call out, we have a quality measure, which is whether or not the pharmacy has the weight of a child, right? So think about this. I have a 3-year-old daughter. She turns 4 on Monday. She has received 5 antibiotics in her life. 2 have been dosed wrong. Because to check the weight of a child, to dose an antibiotic for a child, you need to know their weight. So that's on the prescriber side. But for me, I'm dispensing the medication. My bare minimum standard that what I do to dispense medication is ensure that it's the right dose. So how do I make sure it's the right dose? So I can look at NCPDP data standards. They have a data element, which is weight, coming from the prescriber to me, the community pharmacist, saying, is this the weight of the child? Is it correct? So that's the coming from someone else to me to validate that I'm dispensing something correctly. At the same time, I have scales in a pharmacy. I can plop that little child on that scale and I can collect their weight and then validate that the dose is correct. And so then the data exchange is two ways. Not just is it coming into me, but what am I collecting where I'm at? What's really funny is the data, we did research on it, and we found that about half of all pediatric antibiotics are dosed wrong. Half. That was the case for my daughter with 4 of her first antibiotics. 2 were dosed wrong, 2 were dosed correct. The 5th antibiotic was 2 weeks ago for an ear infection. It was a guest pediatrician. It was not our normal pediatrician. But there was a note on the file that said, he's super uppity. And so the new pediatrician came in, because apparently I'm super uppity, and they asked what I do and what am I focused on, and I said, making sure the dose is right for my daughter. Dude pulled out a calculator and said, I'm gonna do this math with you in real time. That's a good collaboration.
I love that. Ben, what are your thoughts on this? Any real-world examples you can share with us?
Well, sure. I think all the way back to the first project that I came to APHA to do, and it was called Project Impact Hyperlipidemia, and it was focused on the fact that the industry data said that only 28 to 32% of people would be left taking their lipid-lowering med after 2 years since it was initiated. Okay, so imagine that. We know people are at risk for heart attack and stroke. They've been prescribed a med, but they haven't stuck with it. And so in old school ways, way back then, we armed the pharmacists with information and collaborative methods with local physicians and became an integrated part of the care team. Actually did point of care testing that gave the patient a full lipid profile and their Framingham risk assessment to help them understand how they were doing. And 24.6 months on in that initiative, instead of 28 to 32% of patients still continuing with their meds, we had 93.6% of patients still continuing with their meds. And that's because pharmacists had access to data that was shared with them from the physician's offices. Might have been a primary care physician or a cardiologist who was treating that patient. And then the pharmacist shared their history and progress notes back with those physicians, so that it's all about patients, pharmacists, physicians, and other members of the healthcare team creating a seamless flow of information between and among all the members of that care team. That's in the cardiovascular space. We got lots of other examples. That was focused on their lipids. You've got blood pressure. You've got continuous glucose monitoring for people with diabetes, and all kinds of examples where pharmacists can not only be your best friend in terms of helping with data flow based on what Jake was saying, but also they need the data to help to make good decisions to actually empower those patients in their daily lives to be effective self-managers of their chronic conditions.
And these are, exactly the type of use cases that we're exploring as a pharmacy work group. So I think I have a slide, but the first deliverable we're working on is publishing some of these examples of how information exchange with the pharmacy can help inform care and improve care between pharmacists and other providers. And we're looking at then, what does interoperability look like today for the pharmacists in these situations? Oftentimes it's maybe a fax or, even had one pharmacist mention that they have to, mail their care plan back to the provider after they've seen the patient. And so some of these really, interesting stories that pharmacists are up against today, trying to elevate those and then talk about, what ideally are some solutions in order to better connect pharmacies and pharmacists into the rest of the care team to really maximize the impact that the entire care team can have in the patient's health journey. And so again, here's just an example, but I want to talk now with Kevin. If you could tell us a little bit about how some of the pharmacy technology needs are evolving and what are some of the barriers?
Thanks, Meg. So with respect to how technology is evolving and some of the barriers that we're seeing, I would say the main areas kind of fall into three buckets. There's just the interoperability itself, there's eligibility, and then there's billing. And those are progress is being made, but there still are challenges that we're working to overcome. For example, with interoperability, pharmacy doesn't traditionally, most pharmacies traditionally don't operate in a FHIR-based environment. So there's a challenge that needs to be overcome, is how do we move towards that? With eligibility, pharmacists, they need to know, is the patient eligible for this service? Is the payer going to pay for it? So there are challenges with pharmacists having to overcome working with the plans to make sure that their patients are eligible for any given service. And then the billing piece. Pharmacies operate in an NCPDP world, and everyone else works in an X12 world. So pharmacies have a challenge of, well, do I find a way to generate an X12 claim myself, or do I use a clearinghouse that will help me translate that claim? So those are some of the challenges and some of the ways that pharmacies are working to overcome them.
Great. Well, I see we're coming up on time, so this last question is going to be a little bit more of a rapid fire question and answer. So I want to ask each of you, what's one misconception about pharmacy interoperability you'd like to correct? And I'm going to go to Jake first.
Perfect. Thanks, Meg. The biggest one to me is, what is pharmacy data? We were working with some states on rural health transformation projects, and they said, we need to include pharmacy because we need claims data and we need phone numbers, because that's what a pharmacy can get me. They can get me claims and an up-to-date phone number. Claims is not pharmacy data. Claims is health plan data, and better yet, it's paid claims is health plan data. Pharmacy data is, yes, a phone number, but it's also the care that I provided to a patient at a dialysis center when I was replacing their CGM device and helping them monitor their blood glucose. All of that extra information around the things that I do in my community is codified in a pharmacy, and in some areas in a pharmacy statewide database, but not shared with anyone else.
Kevin?
Thanks, Meg. I would say that pharmacy and pharmacists, we see ourselves as part of the overall care team. We don't want to take over someone else's role. We see ourselves as filling a need and complementary to other healthcare other members of the healthcare provider team.
Ben?
Yeah, and wouldn't it be great if, just like the quote from Dr. Gerard that basically said, wow, the pharmacist was amazing. They were transformational in changing the way that that team that he was experiencing actually was able to deliver care. And so the misconception is that, well, we only need information about the patient's medications. As you've heard from the whole group up here, basically, in order for us to achieve the promise of the evidence base that's been built over the last several decades, that basically when you get the pharmacist well integrated into the team, clinical outcomes improve, humanistic outcomes improve, and at the end of the day, the bottom line improves, and we see total cost for care savings over time when you've got the pharmacists working together with patients and physicians.
Well, that's a great note to end on. Thank you all so much for being a part of this panel. I want to open it up for questions, but before I do that, just want to also mention that tomorrow there'll be an unconference session around pharmacy. So encourage you all, if that's not on your radar, to put it on your radar and consider joining us. We'll be talking about some of the topics that came up today, in the provider session earlier, and continuing this conversation. So at this time, if there is any questions or feedback, I think see a hand. Probably have time for one or two. Bren, right in front of you. Oh.
There's a lot of buildup. Now everybody's expecting another good joke.
Okay, good joke. Well, first of all, I'm Matt Eisenberg, Stanford Healthcare. We are thrilled because at Stanford we have really integrated, particularly in our primary care practices, our pharmacists. They're part of the care team. They're on our electronic health record. They have some of those access. The two questions I have for the group are things that you did mention that we find are really, really helpful in the pharmacy space. One is actually artificial intelligence for educating patients. The ChatGPT is remarkably good for pharmacy. We've actually automated, we generate some of our responses to patients when they have questions about pharmacy. Our pharmacists love it. It's actually very accurate and it provides great information. So one of the questions is, are you guys looking into the space of using generative AI to help with patient education around medications? I think there's a great opportunity. And the one other thing that does drive us bananas, must drive you bananas too, is electronic prior auth for medications. Always a challenge. You talked about eligibility, making sure eligibility is right, but even beyond that, formulary information for the patients. It's just a mess. Is that something on your roadmap?
May I actually go first? Is that all right, guys? All right. I'm going to be a bit of a contrarian to you, and I apologize, sir. Again, I gave an example of a rural pharmacy where the patients show up on a lawnmower. They don't have internet. They don't have cell phones, right? And so I love where AI is going. I love how it helps. But I think about the least common denominator, the patients that we help and where they are and what they're doing. And so we've got to meet them where they are, which is in their house, right? And so sometimes that's the barrier that I see in a lot of the rural communities and even some of the urban communities that we work in. Again, I apologize for being a contrarian, but like that was my first thought. The second is, I think what's really interesting about prior authorization is that I can collect the information to help proactively fill out that prior authorization, to share that with the care team for them to attest or validate or confirm. And I think that that's another area of that interoperability of things that I can get that I want to share back with you and that we need to continue to work on.
Well, I would add that I represent chain pharmacies, so from that perspective, you know, our members are looking at AI. It's still very new and nascent, and I'm not sure that they have a full understanding of how it can help in the chain pharmacy environment. But yeah, that is something that I think all healthcare providers are probably looking at. And then prior authorization, I agree, that is a major problem.
Ben?
Yeah, I would say that on the prior auth question, following on to that, it's like more data, real time at the fingertips of pharmacists will be helpful, and more pharmacists being integrated into the overall healthcare system and being able to share the data that they have back with other providers will also be helpful in terms of, you know, for example, if prescribers have information coming from the pharmacies, they may be in a good position to make a decision that doesn't require as much difficulty in that prior auth interaction. I think as it relates to AI, you got to remember, we're trained as scientists, okay, and we're all about the details. You probably know that from working with pharmacists across the spectrum. And so we're trying to figure out how to get AI right. And what we think is that, you know, very structured, quantified data and packaging that and repackaging that with AI in customized ways, to Jake's point, in terms of meeting patients where they are, is one really good place for AI. And then the other good place for AI, probably for all of us in this room, is that it can help us to automate tasks. We're on a very slow trajectory. That's kind of more on our crawl, walk, run pathway, where I would say we're somewhere between crawl and walk right now with that. But hopefully that answers your questions.
Absolutely, and you know, not necessarily a focus of the pharmacy work group at the moment, but I think, as Ben said, you know, automating some of these manual tasks for everyone on the care team, with prior auth being a big factor of that, is definitely something Surescripts has on our radar, and we know that the result of solving some of those complex administrative issues is just going to mean more patient care time that all providers are able to spend, pharmacists included. So thanks for the question. And again, please consider joining us at tomorrow's unconference session. And thank you all again for being on the panel today. I think that's all we got.
Thank you all very much.
Thanks, everybody.
Thank you.
Alrighty, so I want to Thank everybody again. This afternoon break is sponsored by Smile Digital Health, and this is your last chance to register to enter the raffle, and the winner will be announced sometime after the break. And so we would like everybody back here at 3:30, and so fingers crossed somebody wins.